questions that come up that you want to ask our experts, and if we don't have time today to ask them, we'll make sure we give feedback and send it round via our either Twitter or via the email account. We really need your feedback. Like I said, this is our first digital SEN. Hopefully one day we'll be able to meet in person, but the benefit of this is we can reach a wider audience, which is really exciting. But we would like some feedback. So yeah, we're going to be sending around a SurveyMonkey link. I really would ask if you could all spend a couple of minutes filling that out, because that tells us what you want from us as a clinical excellence network. And if you could tweet, if you decide to tweet during the morning, then that would be fantastic. Our username and handle is there at FeesVFSen, and we will be as active as we can be throughout the morning. But I'm gonna just introduce our committee to you now. Oh, no, I'm not. I'm going to introduce our speakers. I like to, I'll do it, whatever slide comes up, I will do. I'll introduce our speakers today. So I'm just going to go through their names, and when we get to the panel, I'm going to give you a little bit of bio on them. So we've got Sarah Wallace, OBE. We've got Anita Smith. We have Alice Howard, Gemma Clooney, Rachel Stiller, Jodie Allen, Anna Lou Sugar, and Melanie Peck. And I'm really excited because we've got a really diverse panel of experts today. So I think we're all in for a treat. I'm expecting to have some fabulous knowledge imparted on my brain. I'm going to introduce you to our committee now. That was a technical issue, obviously. It's not that I wasn't prepared for the order of slides. So our committee, we have a brand new committee, which I am very excited about. They are super efficient, which is really exciting. So for those of you who don't know me, I'm Alexia Young. I'm the chairman. I'm the chairperson. It's going well. I'm the chairperson, and I have been part of the SEN since its founding days. So I helped find it. We've got Rachel Cowley, who has joined us from BHIUT. We've got Orna Doris, who's joined us from UCLH. Amy Endicott, who has joined us from Northwick Park. Anna Lou Sugar, who has joined us from Imperial, and Vicky Brown is back from maternity leave this week, guys, and that is exciting. So the gang's all here. You have a ridiculously proactive committee, so we ask that, you know, if you ever need anything from us, you send it either via the socials or via our email. Cool. So I think that's my housekeeping done.
It's all the housekeeping we've missed. That's all good.
I think that's our housekeeping done. I'm going to hand over to our first expert panel of the morning. So we're going to go through video fluoroscopy questions first. So first up, we have Rachel Stiller, who is our head and neck cancer specialist. She is a Band 7 speech therapist on the head and neck cancer team at UCLH. She assesses and treats patients in both the inpatient and outpatient settings. Rachel's been doing video fluoroscopy for the last 6 years and independently runs the VF clinics at UCLH for all head and neck cancer patients, including those who are pre and post-surgical and oncological treatment. Well, I'm a teaser this morning. And troubleshooting for laryngectomy patients. She's MBS IMP certified clinician and recently successfully completed the 5-year renewal course for this certificate. Rachel regularly completes video fluoroscopies for research projects and supervises junior staff through VF competencies. We also have Anita Smith, who has kindly joined us today. She's a consultant speech and language therapist at East Sussex Healthcare NHS Trust. She has 26 years of experience managing dysphagia in both acute and chronic settings. And Anita is Trust dysphagia lead and runs county-wide SLT-led video fluoroscopy and FEES clinics. And then we've got Jodie Allen, who has joined us from the National this morning. Jodie's a senior speech therapist based where I've just said. She has 16 years experience 16 years of clinical experience in the field of adult neurological and neuromuscular disease. Jodie has expertise in the assessment and management of dysphagia in neurological and neuromuscular diseases. She uses video fluoroscopy as a routine part of her assessment procedures, both to support differential diagnosis and tailored dysphagia management programs. And I know she has Bonnie Martin Harris's number in her phone. So yeah, so that's our expert panel today. So I'm going to go through those questions. So I'm going to start with Rachel first. So Rachel, we've been asked by our FEES delegates, when would you choose video fluoroscopy versus FEES for a post-surgical head and neck patient, and why?
Sorry, can you hear me? I was just trying to unmute myself. Is that all right?
Yes, thank you.
Okay, thank you for the question. Hi, everybody. Right, so normally in terms of choosing instrumentals, I always like to start with my clinical question. So what exactly do I want to get out of this assessment before I choose what I'm going to do? So for example, if I'm looking to maybe assess secretion management or aid in tracheostomy, weaning decision making, I would choose a FEES. I'd also choose a FEES to assess post-operative structural changes. For example, if the patient's had surgery in the larynx, maybe a partial laryngectomy, I could assess changes to anatomy and physiological impacts on swallow, airway, communication.
Oh, Rachel, sorry, I think you got muted then.
Sorry, I did that.
Oh, where did I become muted?
You I just talked about airway assessment, and then you were
right. So I was saying, for post operative surgical structural changes. So if a patient's had surgery in the larynx, maybe a partial laryngectomy or something like that, it would be good to use a FEES to assess the anatomy and physiological impacts on the swallow. You could also look at airway, communication. I can also use FEES for biofeedback. And FEES also can be useful if a patient, for example, is bedbound or can't mobilize well post-surgically. And also we can repeat FEES more often than VF. So it's a more of a repeatable assessment. Video fluoroscopy, on the other hand, I can assess all the stages of swallow, including the timing of stages and impact of one stage on the other. So maybe if a patient's had surgery in the oral cavity or oropharynx, perhaps a subtotal glossectomy, I choose a video as I'd like to be able to see the impact of the changes to the oral anatomy on oral stage of swallow, and then also the subsequent impact on the pharyngeal stage. VF also allows me to assess, anatomical and physiological abnormalities in the upper esophageal sphincter. I also can use the VF if there's significant post-surgical edema that would preclude a good view via FEES, or maybe if a patient, doesn't tolerate scoping for any reason or is dangerous to scope, maybe if they're at high risk of epistaxis. We do use video as well to assess for post-surgical leaks, like for laryngectomies, and also good for patients who are high risk aspiration, because we can use water soluble contrast on video, which is useful. And lastly, I think video is a good way to get a full picture of oropharyngeal swallow. So if you're maybe trying to plan for a rehab block or measure therapy, plan for rehab therapy outcomes, things like that, a video would be good to use as well. Yeah, that's my answer.
Great, thank you. And while you're not on mute, I'm going to ask you your next question.
Okay.
How would you use instrumental assessment to inform your management of progressively worsening dysphagia throughout or after radiotherapy? Okay,
great. Thanks. Yeah, we definitely use instrumental assessment for our radiotherapy patients. Often we, will do baseline instrumental assessments for our radiotherapy patients, namely those who do present with a baseline dysphagia. We might pick something up on the 100 milliliter water swallow. The patient might, describe dysphagia to us. The patient might already have a feeding tube or has been losing weight, or so we'll use this information to determine whether or not a baseline would be useful. Also, knowing where the disease is, we might be able to hypothesize on the impact of the disease presence on swallow, and doing an instrumental assessment would be helpful to gain further information. This really helps us to guide the recommendations for oral intake at the start of radiotherapy, and also kind of the exercises that we would advise, Bahan. For example, if we see a patient maybe has really reduced basic tongue retraction or something, we might focus a little bit more on that with the prophylactic exercises. And it's just really helpful to know where the impairments lie at the start of treatment. So especially if a patient already has impaired airway protection or impaired efficiency of swallow, we need to make sure we monitor these patients quite closely throughout radiotherapy, because their swallow is likely to go off a bit sooner, and just because we know how much radiotherapy can impact swallow function. So yeah, we tend to see our patients, we do see our patients weekly during radiotherapy, so we'll screen the swallows throughout, and expecting swallow function to decline. If you can't get the information that you need from a swallow, bedside swallow screen or tableside swallow, using an instrumental can be useful. FEES, for example, you can repeat throughout radiotherapy to monitor swallow safety, secretion management. You can use it for biofeedback, maybe practicing airway protection strategies, pharyngeal clearance strategies. But just knowing as treatment progresses, obviously as the side effects increase, like pain and edema, FEES at the very end is usually quite difficult. So normally if I wanted to repeat an instrumental assessment, be it FEES, be it BF, after completion of radiotherapy, I would normally wait, 6 to 8 weeks just to allow the initial edema and acute side effects to settle down, so I get a really good picture of where the swallow is and can plan appropriately for a rehab block.
Thank you. That was really, really good. I know we've had a question come up already regarding head and neck. I'm going to ask the rest of the questions that have been prepared in advance, and depending on how we go with timings, will depend if I get to ask you that later. If not, Rachel, I will send you that question from Lucy Singer directly.
Thanks.
And we can answer it afterwards. But thank you for that. That was really helpful. I'm going to go on to adult acute and neuro questions. So this is we're going to have both Jodie speaking in this and Anita. So Jodie, I'm going to start with you. So be prepared to press your off mute button. MBS IMP requires use of barium. How would the interpretation and scoring be affected if using water-soluble contrast for safety instead? And do teams start with a water-soluble contrast first and then proceed to MBS IMP protocol with barium?
Yeah, I think that's a really interesting question, isn't it? And it's one of those that you kind of want to open up for discussion. And at the risk of entering a debate about use of which contrasts, which there isn't huge amounts of research on water soluble versus barium, the impact on the lungs, I can give you a little bit of an anecdote in that I used to work in a trust where Gastromiro water soluble was readily available, and we always used to reach to the Gastromiro just in case. And then I moved to Queen Square and we don't have Gastromiro water soluble contrast available. So for 5 years I've been using video fluoroscopy without any water soluble contrast. And the first few months I thought, oh, how hard am I going to need to fight to try and get this accessible to us? And 5 years on, I've not looked back. So we haven't needed Gastromiro. And I guess one of the questions to put back is, so I guess the reason people turn to water soluble contrast is because of the risk if gross amounts of barium enter the lungs. And I think it's really interesting, Bonnie Martin Harris's work, because they justify the use of that 5 ml bolus to start in a controlled video fluoroscopy suite. And the theory is that, 5 ml of a liquid hasn't hurt anybody so far, and nobody's written about small amounts of barium causing problems. So I guess I want to challenge people's thinking about choice of contrast from the get-go, because we do know we use barium for good reason, in that it's, shows really well upon the x-ray, far better than water soluble contrast, and it passes through the GI tract without any issues as well. And the only case studies I've seen out there are for gross aspiration of barium, where it does cause a problem. And even then, if you look at the dilution of barium in those examples, they're looking at 200 or 250% concentrate of barium, and we use it at 40%, so a lot less. And just out of interest as well, I had a quick Google of the animal models, because they've injected barium into animal lungs, rats and rats and rabbits, and they injected 3 million milliliters of barium into rats. This is not a very nice story, but 3 days in a row, and they did come to harm. But then, out of interest, I googled how big a rat's lung capacity was, and it's 10 mils, and a human's is 6 liters. So just to give you that comparison in humans and rats is maybe quite useful. So I guess coming back to the question is, we don't use it, and we're very careful about who we choose and why we're using it. And I guess my first thought back is, if you're really worried about gross aspiration, that you're using a water soluble contrast, is your patient really fit to go through an entire video fluoroscopy using NBS-IMP in the first place? They're my kind of questions back, rather than giving you a hard and fast answer, but maybe a bit more thought-provoking. I don't know whether Anita's got anything to add to that.
Yeah, I'll take my mic off. So we have access to both in East Sussex. Rarely use Gastromiro for exactly the reasons you said, Jodie. The visibility is much poorer, and it thickens really. You can thicken it, but you have to really dilute it to be able to thicken it. So to get the appropriate IDSI levels for our standardized recipes with Gastromiro, it's really challenging. It's interesting, Jackie Benfield did a paper which was released in 2021, which most of you have probably seen. It's where she explored the landscape. I think she canvassed about 73 acute trusts, which is over 50% of the UK trusts, so really good sample. Looking at who uses what when it comes to water soluble or standard barium, and 44% of trusts have both. But what was really interesting is nearly 14% didn't know. So I think there is confusion over us VF technicians as to what barium we are using, whether it's water soluble or whatever. So I think that is a bigger discussion maybe for another time. But it's interesting.
Thank you, Anita, for adding that on. I'm going to come to you next, actually, so keep your mic on. How would you use instrumental assessment to inform decision management on risk feeding in a palliative patient?
So this is an interesting one. So like Jodie, I use NBS-IMP. That's what we use in our service. And we all have to follow IRMA guidelines, and the IRMA guidelines state that in order to irradiate somebody, we need to have a really sound clinical reason for doing that, and that it will inform our management plan. So for some patient groups, we would potentially use video fluoroscopy in looking at risk feeding recommendations. I'm thinking more probably around the head and neck patients, and that's something that Rachel might want to kind of allude to when I finish my bit here. But the NBS-IMP is any video fluoroscopy is a snapshot in time, isn't it? It is just what we see there. But the NBS-IMP is a really good standardized protocol. It looks like impairment, not just at what they're doing and whether they aspirate at that time. So it's a good protocol to use if you are doing risk assessments regarding acknowledged eating, drinking with acknowledged risk. We have to say that now, not risk feeding. But video fluoroscopy on its own isn't really what I would use for the majority of my patients. So unless it was going to inform a management plan, I probably wouldn't opt to do a video fluoroscopy. The things that I'd want to look at more around comfort, their desire to eat and drink, at what stage of the end of life care that patient was on, whether in the last few days or the last year of life, and whether that patient had capacity and whether we're looking at best interests, etc. So going back to your question, how would I use it to inform decision management on risk feeding? Not overly. if I'm honest. I think it's a more holistic picture. But if I needed to, for some patients, then the NBS-IMP, I think being an impairment-based protocol is a good starting point. But it would be mainly for our head and neck patients, not for those that we already know are aspirating because of what our clinical examination is telling us. Jodie, would you like to add anything?
Yeah, thanks, Anita. We kind of don't use the term risk feeding here because an awful lot of our patients have dysphagia with associated aspirations. So it's a bit of a tricky one to answer. And I guess I would echo what you've said, Anita, about wouldn't routinely turn to video fluoroscopy to assess aspiration, because video fluoroscopy is bigger than that, and I would use video fluoroscopy with an intention to treat the problem rather than put a sticking plaster over it. And I think perhaps gone are the days where we're using video fluoroscopy just to look at quantity of aspiration, or hopefully that's the case. And actually we know that risk of chest infection from aspiration is not directly associated with how much you aspirate as well. So I was thinking about cases where I might have used video fluoroscopy for, in inverted commas, risk feeding cases. And I guess the only example I could come up with was if somebody was palliative because of their risk feeding. So they've made a decision to feed at risk, or there's a decision to feed at risk with a known recoverable treatable dysphagia, but that puts them into a risk of palliation from choking and acute hospital admission. And I might use it in that way, for example, to use for biofeedback and education purposes. That's probably the only good case that I would use it. Other than that, I would turn to exactly as Anita's use things. It's more about symptom relief, I would say, in our palliative groups.
And Rachel, was there anything from a head and neck that you felt could add to that?
Yeah, no, definitely. So we do work with patients who eat and drink with acknowledged risk, and not always they're not always palliative, actually. So I think with what we use the assessments for is, I definitely agree with what you said, Anita, just making sure that what we're doing will actually change and inform management and allow patients to make informed decisions. You can get a lot from bedside. You can get a lot from what the treatment that the patient has had and how the patient presents. So you need to use the full picture. It's not just the video fluoroscopy that gives you the answer. And I agree with Jodie, you're not just looking at, the amount of aspiration. We're looking at the overall swallow function, the swallow efficiency. There's lots to look at. But I do find it useful for some of our patients who, especially have had quite morbid surgeries, who do want to continue to eat and drink, or even, late effects from radiotherapy and are, carrying on living and want to figure out what can I do, what can I manage, and, making this informed decision. And sometimes it's useful for the patient to see the images for that biofeedback, to really understand what's going on, to help with the decision making, to help with the discussion, bringing family members in as well. So yeah, we do use it in our practice for sure. Hope that's helpful.
That's a really robust and rounded answer, I think, from all three of you. Thank you very much for that. Our final question from a neuro and acute perspective, and I'm actually going to ask both Anita and Jodie to come back on this one. The question was, when requested to VF for a differential neurodiagnosis, what are the key components of the different stages to look at in greater detail?
Shall I go first, Jodie? Yep. Okay. So when I read this question, I was a bit, I will say the word flummoxed. I was a bit flummoxed. I looked at it and thought, so is the person asking me, am I using video fluoroscopy to differentially diagnose a neurological disorder? So that's the way I read that question. I thought, no, that can't be right. Unless I've really missed something monumental that's happened in the last 26 years, I don't think we use it in that way. And so I tried to flip it around and think, okay, so are they asking more around what are the typical presentations of a neurological disorder that we might see if we're doing a video fluoroscopy examination, almost like a phenotype. So you may well know, and Sarah might talk about the Munster group later on. So there's Wernicke and Diesvass they're German neurologists, and they tend to manage the fees side of things in Germany. And many of you will have seen a webinar that was run by Raynor, I think it was last month, on the back of ESSD, where he talked through different phenotypes that he identified would have a certain presentation that could identify potential neurological diagnoses. So, for example, pharyngeal residue with predominance in the vallecula, he said, would lead to a possible Parkinson's presentation, not a diagnosis, a presentation. So I know that exists for fees, and I think it's really early days. I don't believe there's much robust evidence base behind that piece of work. I think it is more clinically driven. But it made me think, okay, is there something then for video fluoroscopy which is equivalent? And video fluoroscopy has been around obviously a lot longer, and Jerry Logeman, God rest her soul, taught us lots of different things. And those of you that are as old as me will know, you know, we talked about tongue pumping and Parkinson's, for example. So there are different papers out there which will describe certain characteristics that you might see on doing a video fluoroscopy. I actually had the
Lisa
opportunity
Bowler's
to
feeding, Costas. Lisa.
Oh, sorry, can we make sure we're all muted? Thank you.
So I had the opportunity yesterday to have an email chat with Catriona Steele, which doesn't happen all the time, and I thought I'm going to maximise on this. And I posed the question to Catriona because I thought if anybody knows, she would know. And she was really interesting. And she said, so are there hallmarks that are characteristic that we've seen so far that would trigger us to suspect a particular diagnosis? And she said no. So that confirmed I hadn't missed anything monumental, which is great news, particularly for all my team that I train. And she said there are certain profiles and characteristics, but again, she said I would urge caution on lining those up to particular diagnoses because again, the evidence base isn't particularly strong. The different methodologies of the different research studies are so vast that it's not possible to kind of align them accurately. But she said the same as what we would all think. There are certain things that we look at and think, oh gosh, that looks like it could be motor neurone disease. If we see premature loss, if we see poor pharyngeal stripping, if we see significant residue throughout the whole pharynx, if we see fasciculations in the oral stage and the tongue, we might all be looking at that going, that looks like it possibly could be a motor neurone. And very often you'll all have experience of this. We'll see things that are bedside or under video fluoroscopy that will go, this needs a neuro opinion. I think it could be this. And actually turns out that it is there. So there are certain presentations that would link you to think about that. The fatigue element, obviously, then that would lead you down different routes. So the evidence base isn't particularly strong, but I think as a practicing clinician, there are certain elements that you look at and think, yeah, that makes me think it could be along those lines. And that would then guide your management from that. Because the thing with the NBS-AMP, which I really like, is that it is impairment based. So it helps us to identify, so what are we going to do about that next? Jodie, do you want to come in now?
Yeah, I can do. I think it's really interesting. This is another huge discussion that I would love to have because this is the bit that really excites me about video fluoroscopy. And I guess in our setting, we are referred patients with an isolated dysphagia who are under neurological differential diagnosis. And in those instances, video fluoroscopy does form part of that jigsaw puzzle, but it isn't a standalone. It's not a diagnostic test for any neurological condition like Anita says. So we wouldn't ever use it as a standalone tool, but we would use it to try and make sense of what's happening. But I absolutely echo what Anita's saying, is that you're far more likely to get neurodifferential diagnosis from a motor speech assessment and looking for your hard neuro signs. So as Anita mentioned, tongue fasciculations guide you down, pretty much one pathway. And your Parkinsonian speech is far more likely to tell you that a patient is rigid than a video fluoroscopy. However, there is, for those who do use, I do think as speech therapists, we are, we're better than just describing aspiration. We're better than just saying there's poor tongue-based retraction. We are trying to make sense of what we're seeing on the video fluoroscopy in the context of a known or unknown diagnosis, be it neuro or be it non-neuro. And actually, when I first started working in this area, and it might be a handy reference, there's a video fluoroscopy book called A Multidisciplinary Approach, and I think it's like a plum colour. And it nicely assimilates some of the literature on what does video fluoroscopy look like in Parkinson's disease. So, those cardinal signs like tongue pumping, drooling, all of those you would see outside of video fluoroscopy as well. So what the added value is of video fluoroscopy, I think you have to sit tight and we have to be careful not to overstate what video fluoroscopy is telling us as well, and sit very carefully. But there is an example. We've had 2 patients just after Christmas referred with focal dysphagia, and it's neuro versus non-neuro, and it's really interesting, those discussions and looking at those video fluoroscopies, because one looks like a very focal dysphagia of hyoid movement and one looks much more like a diffuse pharyngeal dysphagia. And what we know about diffuse pharyngeal dysphagia in the absence of oral problems is that, brainstem strokes could cause that sort of presentation, inclusion body myositis. So it starts to inform a little bit of your neurologist's kind of decision making about which diagnostic test where should they go to start with. Do they do an MRI brainstem? Do they do a muscle biopsy, for example? So yeah, loads of great questions on this, and I think the dyad between which components do you look at, it would depend on what depends on what your diagnosis is, doesn't it? So if your patient's got myasthenia gravis, you'll probably look more towards oral phase problems to start with. If your patient has got Parkinson's disease, you would expect to see more likely things like tongue rocking, etc., etc. So there isn't a kind of look at these 2, this will tell you everything. Like I say, you have to be careful not to overstate anything, but use it as an additional tool by all means.
And just to finish off, Catriona did say that they are in their lab, which sounds a very exciting place to work. She says they are starting to collate profiles and characteristics of people with specific diagnoses, but it's a huge goal, she says, and we've got to wait at least another decade before she's ready to publish.
Great, thank you, ladies. That was spectacular. Jodie, Anita, and Rachel, thank you very much. I'm going to, I can't clap for you in person, so I shall do it via my screen. We have had some more questions, so that's really interesting. I'm going to actually move on to our fees panel. I realise we've stacked quite a tight ship, so I'm going to move on to our fees panel, and then at the end, if we have more time for questions, I think that would be really good. But all 3 of you, thank you so much. Your expertise was really valued. Apparently, I was still applauding while I was talking, which is great. So moving on to our fees panel, it's worked in the same way. We've asked our community of followers what questions to ask our expert panel, and I'm really chuffed. We've got 3 really good experts in the room today. So we have Sarah Wallace, OBE, is our critical care SLT at Wythenshawe Hospital, an honorary, someone put that one on purpose, senior lecturer at the University of Manchester. She holds national leadership roles with the National Tracheostomy Safety Project, the Intensive Care Society, and is an RCSLT specialist advisor in dysphagia, fees and critical care. Sarah is a committee member of the Global Tracheostomy Collaborative, RCSLT, Tracheostomy SEN, and COVID Group, and the UK SRG. She teaches and conducts research into laryngeal complications of intubation and tracheostomy, publishing over 60 papers and many policies and guidelines. She volunteers with Speech Therapy Cambodia and was recently awarded an RCSLT fellowship and an OBE for services to the NHS. We also have Gemma Clooney joining us today. She's going to be focusing on our airway and voice specialisms today. Gemma is a clinical specialist speech and language therapist with an interest in voice and swallowing disorders that is particularly focused on the benign ENT, head and neck and respiratory populations. Gemma is a current NIHR/HEE clinical doctoral research fellow at Imperial College, London. I think you've all wound me up with these bios to make sure I get tongue-tied. Her PhD studies focus on the voice and swallowing difficulties of the airway stenosis patients. She's based at Charing Cross Hospital in London, where she works as part of the National Centre for Airway Reconstruction, Europe's largest centre for the management of airway disorders. And our third specialist is our neuro expert. We've got Alice Howard joining us today. Alice graduated from the University of Sheffield in 2010 and worked across acute stroke and level 2 rehabilitation services in Sussex before she moved to a specialist level 1 neuro rehabilitation role at the Royal Hospital for Neurodisability in 2012. There she worked across rehabilitation, long-term care and ventilator units for 9 years before moving to the regional hyperacute rehab unit at Northwick Park Hospital to lead the team as the principal speech and language therapist. She is a co-author of the 2020 RCSLT FEES position paper, has written several journal publications around prolonged disorders of consciousness, and has recently completed an MSc in acquired communication disorders. Alice is a level 3 FEES trained and is particularly experienced in using FEES in the severe neurodisability population, including patients in PDOC and those with a tracheostomy. Now, I think you all realise by my articulation that it's time to hand over to our speakers. So we'll start with questions. Sarah, I'm going to start with you first. So get ready to unmic yourself. Do you comment on whiteout completeness? And if so, what do you associate with reduced whiteout in terms of impaired swallow physiology?
Thank you. Hi everyone. Thanks for having me on this panel. So that's a question that comes up quite often, and I think if I think back to when I was FEES trained many years ago by Susan Langmore, she taught me to always comment on whiteout, and I think the reason this question comes up is because it's a bit nebulous and we don't have a rating scale for this. We don't have a nice, neat way of reporting it. So people kind of get a little bit lost on, so what, what do I say about it? I think if we just clarify what it is, just so everyone understands what we mean, it's literally the flash that you get on the screen when during the swallow, as the pharynx constricts around the scope. The light comes back up, and by definition, then, if you've got weak pharyngeal constriction, you don't have good closure around the tip of the scope. So it implies that there is pharyngeal weakness. You can't quantify that weakness, and pretty much all I say is whiteout complete or whiteout incomplete. And if you can see structures through that maximum point of constriction, then you know you've got a problem. But so it is helpful. It gives you an indication that the pharynx is weak. Depending on where the tip of your scope is, if the tip of your scope is round about the base of tongue, then perhaps there's weakness in the base of tongue movement as well. But there are lots of other things that you would be doing during your FEES procedure to sort of add to that. So obviously, if you've got residue coating pharyngeal walls or in the vallecula or in the piriforms, you also know that that constriction is weak and the pressure that you need to drive the clearance of the bolus isn't there. So I think it's important. It tells you something about tone. It tells you something about that constriction. But also equally, I would include things like a high-pitched E sound to give you some indication of that lateral wall movement when you're doing your structures assessment at the beginning. So that also helps. So it's difficult to describe it. I think that's why people go, well, why am I saying this? What am I looking for? But yeah, just pay attention to it because it's helpful to tell you if things aren't very strong. But you will see the problem in clinical symptoms like residue, and And you will also be able to see generally if the tone of the pharynx doesn't look right. You know, you're meant to see a nice concave picture on the screen, and if you're seeing some asymmetrical collapse of the pharyngeal wall at rest, things look wonky. I won't use the term wonky in my report, but you all know what I mean. Or things look flattened, and your patient's general presentation is of reduced tone, then all of that helps to form a picture for you. So yeah, pay attention to it, describe it as whiteout, incomplete, complete, and what you're looking at is the strength, I think. Will that do?
Great, thank you. That was a great answer. I felt like we
Cool.
were doing catchphrase halfway through when you say what you see and it's wonky. Next question for you, Sarah.
Okay.
Can you talk through your assessment for a trach event patient? For example, do you always go with the cuff up first, visualizing when you deflate the cuff, and move on to P&V insertion if appropriate?
Okay, so this is probably a lecture in itself, but I think I'd like to just step back a little bit from the actual procedure bits first, because I think when you're assessing using fees with a trach event patient, I think that there are a few things that you need to do in order to make it a really, really effective assessment. So first thing is getting the timing right. So deciding when is the right time to do fees on that patient. That's probably one of the hardest things, actually, I find. For me, it's usually really early because I really like to get a handle on secretions and structural issues, laryngeal integrity, potential tracheostomy weaning issues. So as long as my patient is awake and not fighting me, not too delirious, it's good to get in early. So timing, but that's going to vary, obviously, depending on your patient. But timing is important. The purpose and the sort of rationale and your clinical question will determine what you're going to do. So, whether I start with the cuff up or cuff down depends on what I'm actually looking at. So if I want to assess the effect of cuff inflation and deflation on the secretions, perhaps the movement, the swallow efficacy, the aspiration risk, then yes, I would definitely do that during the procedure. If I want to assess the effect of using a one-way valve, I would definitely put it on, take it off. If I want to assess the effect of above cuff focalization, likewise. And I would do them in a logical order. So yes, probably if I arrive at the bedside and my patient is cuff inflated at the bedside, I'd start like that and then proceed through all of the different trials in a very systematic way. It's really important, I think, with these patients to be super systematic. One of the things to also do to make it work well and get it done in an efficient way, so your patient isn't being scoped for too long, is make sure that you've got all the right people there. So if you need the nurse there or the physio there to do suctioning, that they're there and that you've talked through before you start, before you put the scope in, you've talked through the order of proceedings. So everyone understands, right, when I say this, I need you to do that. I need you to suction at this point. So everyone understands the process. And it's all worked out and clear in advance. You could even have a checklist, have it written down, so that there's no messing about running up, sending someone to run off to find a speaking valve adapter or connector or whatever. So work out who you want to be there. And if you want the doctor there, so that you can look at the airway together, and identifying risks as well, because obviously these can be a risky population. They can be unstable, and there could be a particular patient group which has certain risks. So for me, I work a lot with patients on ECMO who are tracheostomized awake. So they have bleeding risks that we have to mitigate. So just being aware of any risks and mitigating those and planning for that. So for those patients, for example, we've worked out with the consultant that sometimes they may pause the anticoagulation therapy just before we scope in order to reduce the bleeding risks. So it's ways of working that through. And I think looking at laryngeal integrity is so important in these patients. We know that they have very high percentage of structural problems, edema, erythema, vocal cord mobility issues, particularly the COVID ones. There's a couple of papers out. One of them's a paper that we did at Wythenshawe, which showed like 75% of the patients with COVID have edema. Most patients have at least 3 laryngeal abnormalities. So looking at the structures is key. That's the bit you do first. There's another paper by Sandblom and their team, which also found these very high rates of laryngeal abnormalities that definitely impact airway and weaning. So there's a bit of research there come out around COVID, and it's probably double the proportion that we would see in the non-COVID ICU group. Secretion management is so important. So before you do anything, have a look at secretions. We use the New Zealand scale to rate them. And again, you may wish to deflate cuff and use a one-way valve and see the effect on secretions, and rate the scale each time. Does it change anything or not? And then looking at sensory aspects, because most of these patients are desensate. Sometimes they're hypersensitive, but most of the time they're desensate. So I think just being systematic and looking at, obviously, then is it safe to do any oral trials? And sometimes it's not. Sometimes you'd stop at that point. So if I'm going to progress through, I need to look at my patient individually and work out what stage are they at in the weaning. What do I want to, I generally want to trial them on every situation they're in. So if that patient is transitioning to cuff down, but not cuff down all the time, then absolutely I want to see them in both states. If they are having ventilator pressure support sprints where that's reduced, I'll also trial that during the FEES. So whatever is going on, I want to trial it in every way so that my management can be very prescriptive around, only safe on this under this set of circumstances, because these patients are fragile. And I think just tailoring it to your individual patient is the key, and being really, really, really clear and communicating to the team what it is you're going to do to make it an efficient procedure. Yeah, I think that's it. Oh, there's another thing, sorry, just to say, there's a really nice summary about secretion management assessment in Current Opinions of Otolaryngology that Anna Miles has done. So she talks about reporting on secretions and the effect, the things that we can do to manage them. So for me, a FEES is about being super proactive. I'm not just having a look, I'm actually coming up with a plan. So if I see reflux issues, we want to make sure they're on the right PPI management. If we see secretion management issues, we don't just wait. What can we do to manage those with medications, etc., so that we can facilitate weaning? So it's all about pushing the patient's wean, and even things like dexamethasone for edema issues sometimes. So yeah, it's about proactive early assessment and assessing them in every state. Is that all right?
That's great. Yeah, that was great. Thank you so much, Sarah, and some really interesting research articles that I think people can look into. Gemma, it's your panel time, so I'm gonna ask you to unmute yourself. Your first question for you. In FEES with head and neck cancer, we sometimes don't get a good view of the glottis due to edema, or cannot get to the glottis low position quickly enough because of the edema or pain. Although FEES gives us valuable information about structures, edema, secretions, we often feel unable to make a decision about penetration and aspiration because of this, and may still need a VF referral. How do the head and neck teams decide what is suitable for FEES? And I've asked you that because from an airway perspective, I imagine this is the majority of the patients you see.
Yeah. Can you hear me okay? Because I don't think we've checked my mic. Perfect. So the short answer is yes. You can't necessarily see aspirational penetration in patients that have airway edema or any kind of airway, inhibition, whatever that might be. But it kind of comes back to some of what was discussed in the videophroscopy panel, which is why are you doing the assessment in the first place? If really all you're interested in is aspiration and penetration, then FEES probably isn't the right assessment for you anyway. And to my mind, it can give you an awful lot of information beyond the kind of binary, are they aspirating, are they penetrating? As Sarah's already kind of very clearly laid out, you get so much information about secretions, about structures, about the anatomy. And especially if you're using kind of clear-cut rating scales every time that you're doing your fees with your patient, you're going to be able to chart changes, which can be really, really helpful. It can be, but basically, I suppose I can see fees for, in this particular question, head and neck patients, but also for my airway caseload. It's a really good starting point to be able to guide decision making alongside your clinical assessment, because as we know, our decisions are going to be very different for patients who are mobile and cognitively intact and have clean mouths. If they're aspirating, then maybe we don't, is that actually that relevant? I would also be liaising very closely with my surgical colleagues about what they're happy with in terms of, you know, what we describe as risk, but effectively might just be someone's normal swallow, particularly in the airway stenosis patients that I see. You know, aspiration isn't unusual, and that might be their baseline, and it's nothing to do with their surgery. So I think we need to be really very careful and very cautious about kind of using instrumental assessment purely for, are they aspirating, are they penetrating, and think in a lot broader way. But obviously there are some patients where you're going to want to refer for a videophroscopy, because that is going to give you a lot more information about what is going on, particularly with someone who has got an airway that is limited, because you just won't be able to get the view below. And for example, if there is a stenotic segment, so if they have got narrowing, you'll be able to get a lot of information about that on videophroscopy. So from a surgical perspective, for planning, that can be quite helpful as well. It really just comes back to that question of, why are you doing an instrumental assessment in the first place? What is it going to add? And if your answer to that is, well, I want to know about aspiration and penetration, don't do the fees.
That's great, thank you, Gemma. Another airway question for you. What would you expect to see on a swallow assessment if the airway wasn't patent above or below the glottis? And how would that influence your management? So this is, I'm sure this is probably your PhD, but if you could summarise it in about 5 minutes, that would be great.
It's certainly almost all my patients. I'm not very used to seeing patent airways anymore. I get a bit excited when I'm like, oh, look, you can actually see the subglottic shelf. Anyway, so it's a bit like the answer to my previous question. You will still get so much useful information about anatomy, about secretions, about residue. You can use the scale that Sarah's already mentioned in terms of secretions, so the New Zealand scale, which is the one that we use. For residue, at the moment, we're using Yale, but I think we're hoping to move over to VASes once kind of people have done training and have read about it. Another thing that can be really, really helpful with patients who have any degree of glottic limitation or airway limitation, whether it's supraglottic or subglottic, you can use a FEES to actually assess their kind of airway response. So use the sniff, see, can they abduct their vocal cords? You know, you want to be able to have that information. You can also get quite a lot of information about their breath swallow pattern and their breath kind of voice pattern as well, because to my mind, it's all very interrelated. So you should never really just be doing a FEES and only be thinking about swallowing, even if voice isn't within your kind of area of clinical work. You want to be thinking what's happening with their vocal folds. Are they able to adduct? Are they able to abduct? Because you're going to be getting so much information that you can then again use within your MDT to help guide management. I also want to make the point that sometimes having a kind of a patent airway isn't beneficial to swallowing. So for some of my patients where they have a restricted supraglottis, that's actually protective. And so one of the reasons that we end up doing baseline swallowing assessments before, for example, something like an arytenoidectomy or a pepper potting procedure, which is where the surgeons use laser to kind of reduce some of the swelling in the supraglottis, we will do it to see whether or not we think that that surgery is going to make them at a higher risk of aspiration, because it's opening the area up and the patient themselves might be quite used to it being very tight. So again, you've got to think about why you're doing the assessment and not be alarmed just because you can't see what you always expect to see. There's always that sense of you just need to describe what's there and use the techniques that you use for any patient to try and get as much information from the assessment as possible.
That's great, thank you. I think it's a really interesting area to talk about. Sarah, have you got anything to add to that?
Yeah, I was just wondering whether or not the person who asked this question might find a paper helpful. There's a paper by I don't know how to pronounce this, but Lab8 2021. It was in JAMDA, and it's comparing simultaneous FEES and VF and looking at the aspiration ratings and residue ratings and the false positives that you get sometimes with VF, actually, because of the lack of lateral view, and obviously with FEES when you lose the view momentarily. So it works both ways as well, but I completely back up what Gemma's saying about not focusing on aspiration. The other thing is that the narrow band imaging, which some people are using on FEES now, which gives you extremely high resolution images because it filters out certain wavelengths of light and focuses on vascular and mucosal things, actually is much more sensitive to aspiration. So I think you potentially can overdiagnose that as well. But yeah, just to throw that paper in. Thank you. Yeah, I think it's oh, I'm loving this. I wish we'd have booked a full day out because I could talk about this all day. And similarly for video fluoroscopy. I'm going to move on to Alice just to make sure we do get everyone in and get everyone's expert opinion. So Alice, it's your question time. Please unmute. What is the level of cognitive impairment that prevents FEES from being completed, and is there one? And when completing FEES with those with severe brain injury, what is the assessment structure and how do you navigate any behaviour or cognitive difficulties? I'm sure that could also be a paper, but if you could try and limit your answer to 5 minutes.
Yeah, thanks everyone. Yeah, hi. So just to give context, I work in a setting with a lot of people with severe and complex brain injury, including a lot of people in a disorder of consciousness. So I'd say the majority of my patients can't follow commands. And therefore, in some settings, you might say, they're not going to be really suitable for instrumental assessment, including FEES. However, I personally wouldn't be without FEES. I think it's really, really useful for our population, entirely because they cannot participate in any bedside assessment at all. You can't do an oromotor, you can't get them to cough to command, all those other things that you might do if you weren't going to be exploring an instrumental assessment. So we find it really, really crucial. We can do a FEES in an entirely passive way. We often are using FEES to assess saliva management for people who are trachea weaning, but also people who don't have a trachea and who are experiencing recurrent chest infections or symptoms of poor saliva management. And that includes people who are in a vegetative state, so have no awareness of themselves or their surroundings. Obviously, you're not going to get as much information as if you can have the patient follow commands and doing the different vowel sounds and that kind of thing to look at their structures and their physiology. But on the other hand, it's better than going in blind and doing a trachea wean without knowing what their saliva management and their airway protection is like. We also can use it as an adjunct. If we're doing a kind of multimodal assessment of someone's responses, we might look at someone's response to tastes and their response to oral intake in context as a way of looking at their awareness. So occasionally we would do a FEES if we wanted to progress with that oral trial with that patient, but that's fairly rare because it's unlikely you'd be going beyond much beyond taste or assessment. So in terms of how we would structure it, it's not that different from how you do a FEES in someone who can actively participate, except you're not going to do as much. You're not going to be able to do as much. Once you've sighted the scope, you're not going to be able to ask them to do any kind of manoeuvres to look at their vocal fold function, for example. So you're just going to sight the scope, look at their anatomy, and then do your usual assessment of their saliva management or their response to oral intake. And as Sarah said, if they've got a trachea, then you do whatever their normal range of trachea management is, so cuff up, cuff down, one-way valve, whichever. In terms of behaviour and cognition, you do have to be very careful about who you try a FEES with, if they've got agitation or confusion as part of their presentation. especially if they've got lots of active movement in their hands or their head, and they're going to pull away and potentially cause themselves harm. So you have to be a bit selective about who you choose to do a FEES with. But on the other hand, people can surprise you. You get a very agitated patient who you think is going to be a nightmare, but actually on the day they can cope. And equally, someone who's, writers very normally can suddenly become quite agitated once they've stuck something up their nose. So I don't think you can necessarily rule someone in or out. It might be worth giving it a go. And to try and manage it, you'd want to carefully explain the procedure to that patient, adjusting to their level of understanding and how best to communicate with them. You'd follow your local policy around consent with a mental capacity assessment or best interest decision. We might use lidocaine if we think someone's going to find the procedure more comfortable that way, but we do tend to avoid it if we can. We don't use it as standard. We also look at how we might be able to adapt the assessment context to make it more acceptable for them. So would they like a family member to be holding their hand? Is there some favourite music we can have on? Is there a video on YouTube we can show them to distract them as we're getting the camera in place? So it's really just like whatever you can do to make the context more acceptable to that person. But we do have quite a low bar for discontinuing the assessment. If someone's finding it too distressing, you're not going to get a good picture of what their swallow is actually like normally when they don't have a camera up their nose annoying them. So we have quite a low bar for discontinuing, and we might come back at another time when they are able to engage more easily. Obviously, you might need to consider your use of restraint in this context. I mean, I think we've probably all held someone's hand and tried to prevent them from taking the scope back out of their nose, and you have to be careful of how you go about using constraint. You should have a local policy about when that is appropriate, have training to do it in the right way that's safe for the patient, and you should be documenting if you do use some form of restraint as part of your FEES procedure. You should be documenting that to make sure that it's kind of above board. But as I say, if you're using very much restraint at all, you should probably be thinking about discontinuing, because is that in the patient's best interest? So that's what I would say.
That's great. Great, robust answer. I'm going to ask you another. Do you use FEES as biofeedback, and for which patients and how?
Yeah, thanks. So I love using FEES as biofeedback, generally because it means I've got a patient who can engage to that level, which is fairly novel for me. So the patients I would choose to do that with are people, there's normally two different groups. It's people who are like cognitively good, but maybe have something very focal that's going on with their dysphagia, so like a brainstem pathology, which means their cognition is a lot better than their swallow function. And that might be people who are post-tumor resection or have had like a brainstem stroke or something like that, because they are probably going to have quite good ability to take in the information that they're seeing on the screen and follow your instructions to try and improve their swallow function. And then the other people I would maybe think about biofeedback for is those who don't have any insight about their swallow function and need it's more the education aspect of the biofeedbacks, is to show them the screen, show them their own swallow, and help them to understand why you're asking them to do all these funny strategies and why you're being fussy about what they're eating and drinking. And in terms of how I go about it, it completely varies depending on the patient and their swallow and their cognitive level and their ability to engage with it. But in general, I would be wanting to show them the images that we've gained, probably do a few trials and gain some images and get an understanding of it for yourself, and then turn the screen around, show it to the patient, really carefully explain to them what they're seeing, because patients will not have seen their own larynx and pharynx probably before. So explain what they're seeing, and then trying a range of strategies to try and make their swallow as good as it can be. So you might be trying some actual maneuvers, or you might be getting them to hoik up their secretions and yanker them, or anything that you think might be helpful to manage their risk or to help them to enjoy the food and drink that they want. Or you might just kind of sit and ask them to look at the screen and just explore how they can make their swallow better. It's a bit like, I think Maggie Lee talks about with SEMG, you just need the patient to kind of orientate to their swallow. When I do this, this happens, getting them to understand what their attempts to swallow, what the effect of that is, and how they can make their swallow as good as it can be. And then as and when you do find something, a strategy or a cueing phrase or a technique that the patient identifies themselves that does work, that does make their swallow more effective, then you want to practice that outside of FEES as well. So and probably do it quite quickly after the fees to make sure it's still in their memory, to have that kind of that feeling of it, that perception of it still there. So I would want to do those exercises or strategies outside of the fees quite regularly, and then go back to the fees to check in and see change over time, hopefully. I've had patients where we've done a fees like a couple of times a week during their rehabilitation stay to kind of, it's been one of their main tools for their dysphagia rehab. But obviously I'm privileged to have that option of seeing patients that often and doing fees that often if we need. So I understand that might not be realistic for everyone.
That's really great, Rachel. Thank you. That's really, really helpful. I think we've had a real broad spectrum of speakers for our panel. I would ask if for any of our speakers, we've been asked in the questions, can if you've mentioned any papers, can you let us as a send know, and we can populate to our distribution list for today's event, because I think sharing resources is really important and powerful. I'm just aware of the time. We've got one more presentation, so if we have time at the end, I'm going to ask all 6 speakers for our expert panels to come back on, and we might be able to follow up some questions that we've had. If not, like I said at the beginning of the session, we will be sending them around and asking our speakers to just spend a little bit of time answering those questions, and we will distribute the questions that have been asked, that have been missed today. But I'm really keen, because I think since 2016, when the SEN was started, I'm not sure we've had a paediatric fees talk. So I am very excited about the next 15 minutes. We're going to have Melanie Peck and Anna-Lou Sugar talking to us. Just to give you some background, Melanie is the clinical lead for acute paediatrics at the SLT at the Royal London Children's Hospital. She specialises in neonates and children with complex airway and respiratory for the past 7 years, but worked for 10 years before this with acquired and progressive neurological conditions with both children and adults. Anna-Lou, our joint speaker, works at Chelsea and Westminster, and she has worked there for the last 19 years as the clinical lead for acute paediatric SLT. She specialised in neonatal and paediatric dysphagia. She's served various national and international committees, including NICE, ESP, GHAN. I don't know how to say that in an acronym, so I'm just going to say the letters. And has recently published a scoping review on the use of paediatric ultrasound in paediatric dysphagia. She's contributed to various publications in the field of paediatric dysphagia as well. And she's the module coordinator for the MSc in Applied Paediatrics at Imperial College. She's currently in the second year of a PhD at Imperial College researching competent pathway design for management of paediatric dysphagia. And she set up the FEES paediatric service in 2014 alongside her ENT colleagues. Ladies, I'm going to ask Amy to share her screen so we can see your presentation and you can wow us with your paediatric knowledge. I'm going to hand over to you. Anna-Lou, I believe you're starting.
Yes, thank you very much, Alexia. And thank you very much for the opportunity to join your team. We're in a very we're a small minority, so we thought it would be better to join up and learn from all the people in the adult world, as you've been doing this for far longer than we have had. So I am joined by my colleague Melanie, who has a very well-established FEES clinic, I think, and that's why I've chosen her to support me in this today. So I'm just going to go through a very short survey that I've done just to show what has been happening in the paediatric FEES service in the UK. Can I have the next slide? Thank you. So we did we've got an acute pediatric dysphagia network. It's not quite a SEN, but it's more a sort of a peer support group. And we've sent out a SurveyMonkey to the various services that you can see on the slide. So we wanted to establish who was doing FEES, what the banding distribution was of the speech therapist doing it, who was scoping, and how many approximate studies there was being done per year. Next one, please. So as you can see, it's very, very small number of services that do FEES, and sometimes in more tertiary centres, the FEES is more, or scoping is more used to look at in voice clinics. There's majority are very senior speech therapists who are leading the FEES services. There was one survey that replied on the adult FEES service, so that sort of skews the numbers a little bit. But I thought what was really good is that there is potential of lower banding therapists that are being trained up, which is a big thing for us in pediatric dysphagia. We are in dire need to grow a workforce. Can I have the next one, please? Looking at the combination of or the makeup of the MDTs, the majority has only speech together with ENT, and then one service has a slightly larger teams. And can we have the next one, please? And I think this is a really significant finding, and something that, of course, we know that are doing pediatric FEES, is that in the majority of cases, it is the ENT surgeon who scopes as opposed to the speech therapist. And although some of us do have the competencies to scope, it is really one of the trickiest things to scope a child. During the previous talk, you alluded to, compliance, etc. Well, if you want to take that to the next level times 1,000, then in pediatric dysphagia, you've got one chance to pass that scope, and that's it. And so Melanie also agrees with me that why not use the people that are super proficient in scoping, and we then focus mainly on the running of the FEES procedure and the sort of co-analysis of our findings. Next one, please. So also very, very small number of studies. I think 2020 to very recently have really skewed our results because of COVID. Pediatric ENT came to a complete halt. So we're dealing with quite a backlog now. So hopefully we'll do more, but my service would be roughly the same, about 10 to 12 studies a year. Next one, please. So just to end my talk is just looking at my positive and sort of more challenging experience. I think it was for myself as a senior speech therapist an amazing opportunity to be able to expand my scope of practice and to be able to offer this to our patients, especially the ones on NICU, etc., that are very difficult to transport down to X-ray and might not be appropriate to do a videophroscopy for an instrumental assessment. I've had tremendous support from my adult speech therapy colleagues, even from the day I started to investigate the possibility of setting this up. They were rather cautious to deal with the little people, but always in the background to help, and then very supportive ENT colleagues, lots of managerial support. And I think another example is to be able to access this SEN, to be on the committee and hopefully move things forward. Sorry, that's the phone ringing. And then the potential of growing this in pediatric practice. Of course, on the challenging side is setting up a service. We all have that, business cases, etc. Training was a big thing. I had to self-fund some courses in the US, especially with Cincinnati Children's Hospital. It was difficult to find people who can supervise. Again, adult speech therapists were very reluctant to go down that route. And then we do not have that much support from college at present in terms of the position paper, which covers very little on pediatric FEES, but hopefully we'll change that. So that was just a little snapshot in a nutshell. So I'll hand over the stage to Melanie. Thanks, Melanie.
Hi, thanks, Anna-Lou. Just as an FYI, I apologise for the awful green background behind me, and just to let you know that Anna-Lou let me know that I was presenting last week because we decided I'd jump on. So no beautiful presentation from me, just my boring vocal acrobatics for you. So basically, I would say it was about 4 years ago that I decided, okay, we really should be thinking about FEES for the paediatric service. So I'm in an inpatient setting, and we have a weekly videophroscopy clinic. But actually, the thing that drove me forwards for FEES wasn't necessarily the super dysphagic children. it was actually the respiratory children. So we are a specialist centre for tertiary centre for respiratory conditions, and I was having loads and loads and loads of referrals for, as we call it, typically developing children who had just had recurrent chest infections, recurrent episodes of wheeze, difficulty managing their airway, multiple complex etiologies in terms of allergies, rhinitis, dust, pollen, all the rest of it. So I was looking at these kids, and basically I'm kind of like a last stop for respiratory team. We've looked at everything, Mel, and we can't find anything else. Can you have a look? And I said, well, I can have a look, but all these children are developing, are typically developing swallow. Okay, they're eating and drinking normally. There's no history of dysphagia. So basically, but they still wanted a videophroscopy because, of course, it's safe or unsafe swallow for our lovely medical colleagues that I'm slowly bringing into the way of understanding physiology. And also we've got a developing population. So a lot of the time in pediatrics, I'm seeing, if you do a videophroscopy, I'm seeing blips on their swallow, but is it risky? Is it not risky? Is that typically developing? If we think about the speech production of a child, we're not expecting them to have perfect speech until possibly they're 8 years old. Okay, if you can think back to your PACS phonological analysis. So actually, if we're thinking about typically developing swallowing, it's not going to be perfect. So sometimes we're then getting these things, well, what does 1 or 2 penetration events mean for a child who's getting sick regularly? So it's the age-old problem about aspiration versus not aspiration versus actually do they have a dysphagia? So I really wanted to steer away from videophroscopy because as well, these children have typically had lots and lots of chest x-rays, lots and lots of radiology. So, and also I felt that we just needed more of a dynamic airway assessment. So I applied to the charity fund at Barts Health and was awarded £40,000 for my own training and to get a new Pentax completely new mobile device for FEES. What scopes do I use? I use normal adult, the smallest size you can get in Pentax. It is not, when you're looking from a fibre optic point of view, like if you can go smaller, but then you're not really seeing what you need to see and actually need to see stuff. So as you all know, preaching to the converted here. So basically that was my my route in. I wrote a long-winded application form, and obviously I got ENT on board. I actually spoke to the adult speech and language therapist in the hospital, and I guess, you know, very, very supportive, and we had a couple of meetings. But actually in terms of like getting the service going myself, just because of and COVID and all the rest of it as well in the middle, it's been tricky. I've just kind of been flying free on my own. But I have ENT, and so our clinic is slightly different. So it's called Ta-da! Okay, so very pediatric, but also very male. So it's therapeutic and dynamic airway assessment clinic. I nearly forgot the acronym then. So, but it's meant to be ta-da, because here's the scope, ta-da, and you get to see the inside of your throat, and it's really exciting, and we have to pitch it like that to get the kids to even have the spaghetti down their nose. So it's called ta-da, and actually it's a clinic with myself, ENT, and the respiratory consultant. So we are all there in the room at the same time for one-stop shop. And really we're kind of doing, you know, what you guys know in the adult world is sort of the feast. So I'm looking at swallowing, but I'm actually just looking at their anatomy. I'm looking at their secretion, their saliva management. Sometimes for some of them who have kind of physio techniques for cough, I'll look at their cough, look at clearance, is it effective? A lot of these children are presenting well, I get referrals. This is a classic referral literally this week. Grotty cough, Mel, can you have a look? So I look at grotty coughs and look at whether there is anything going on in the upper airway, but as a team, so looking overall at what's going on and trying to steer away from this aspiration versus non-aspiration, safe versus unsafe swallow, and trying to look overall at what's going on for this child with a real MDT head. So that's my little clinic. We are actually after this meeting, ENT and respiratory are pinning me in a room because they said you need to write this up. So of course they want me to write it up, but I think they are going to support me. So it's really about getting the word out there that we are starting FEES in paediatrics. What's the youngest child I've used it on? I have used it on a 36-weeker with ENT. Mostly my kids are kind of 6 to 15-year-olds. More from the point, I mean, you can't, video fluoroscopy on a 2-year-old is a total nightmare. I don't know if any of you have kids or you are a godmother like I am, and they just, you know, it's very difficult to get them to sit still. So it's just being open to it, being really excited about it, looking at what we can contribute to all the adult research that's out there, and really kind of bringing PEDS into the forefront a bit more and looking at it. And I think it has been a bit of a kid's glove approach in the past, and certainly when I moved into paediatrics, it was very much, oh Mel, I don't think we do that in paediatrics, but I came from an adult background, and you know, I used to be quite like quiet about that, but actually that's what's helped me move this service forward. So yeah, so I think that's probably about it. You probably heard enough of me, but yeah, so any questions, very happy to discuss.
Thank you very much to you both. Sarah, I didn't know if you just wanted to respond with regards to Anna Lou's concerns with the position paper, because I know that you led on that.
So yeah, I'm kind of glad that came up actually, because maybe I could shed a bit of light on where we're at with that. So I led the FEES position paper revision, which the work started on that in 2019, and I remember at our first meeting I set out what I saw as my priorities for that revision, and it was very, very high on my list to have certain areas included, pediatrics being pretty much the number one, because it's not that it's been neglected, but there's been nobody stepping forward to help shape that position paper. So I was desperate to have some pediatric input to that, and we did have somebody advising who was part of the expert group writing the paper, but I guess it's a work in progress, and I think it's really, really important that when we do the next revision, I don't know when that is, but that I assume that will be quite different from how it looks now, because obviously it's a skeleton and bare bones as it stands. The other areas where we felt FEES was burgeoning also have sections which are quite short, but at least there's something there. So, for example, laryngectomy, or using endoscopy to look at the effectiveness of cough assist, MIE. So there's certain areas where we are evolving practice, and we wanted to include something about paediatrics, but we really, really struggled to find anyone who was willing to pin down protocols or, you know, sort of anything of really meaty. But I think we've started it. We're all, yeah, I think the next revision, obviously, it's going to be much more bulky, and all this work that you're doing, Melanie and Anna Lou, will, I'm sure, help to really shape things as we move forward. Because, as you say, it's not established, and it's important that as it grows, the policy keeps up with that. So your input, I'm sure, would be incredibly useful. But as I say, we've no date for the revision, but at least we have something there. I just thought it was good for people to understand the background maybe to that. Does that clarify things a little? Hopefully.
Great, thank you, Sarah. Yeah, and now we've found two speakers. It sounds fascinating. Melanie, I have to say, your infectious personality was making me smile. And I've never worked with peds in my life, but I'm almost convinced I'm going to come to Tadar Clinic. We've only got 4 minutes left, I'm afraid, everyone. So I'm not going to ask any questions because we did promise it would only be 90 minutes, and you are most likely all, I mean, some of you may have taken annual leave to come to this amazing event, but I'm sure some of you are going straight back to work as soon as this is finished. So I'm not going to ask any further questions. We have got them, and like I say, I promise I will send them to the speakers and you will get your responses about those questions. But I just wanted to say a huge thank you to all our experts and panel today. It was great hearing from all of you. I have missed running this SEN, and I think you've all done an amazing job of presenting. So thank you very much from me. Just a reminder, there is the SurveyMonkey feedback form, which we really do benefit from receiving, and the more detail you put that on that, the more likely we can make your event something that you want to come to. Any emails regarding future events, please email our email address, which is there, feesvfsen@outlook.com. Tweet us at feesvfsen, and I look forward to seeing what Twitter stuff has been going on in the background. I was asked at the very beginning of the talk to mention that UK SRG is running next week and there still are places available. So can I please ask if anyone is interested to register there? That would be great. The SEN has been recorded and we're going to put snippets up on our socials. I say socials, we've only got Twitter and email, but that sounds so much better. I'm getting used to presenter speak. So I'm just going to carry on with socials. Once again, a huge thank you to our speakers. A huge thank you to the new committee. They've been blooming amazing today, so and leading up to this. So thank you very much. And thank you all for taking the time to come and speak to us today. It's lovely to see all your faces. Have lovely days, guys. Thanks very much.